Good afternoon, everyone. My name is Dr. Iseko. On behalf of Cardiocare and the Limi Hospital Network, we have this full webinar that we are offering to Nigerian doctors and healthcare providers, where we are teaching on several things that we think will be of benefit to your practice and to your patients. With us today is Dr. Olalekan, Dr. Pathophysiology, Dr. Eroja, and we'll be discussing management of asthma. So we had quite a number of requests on asthma and also on hepatitis. So this week we're talking about management of asthma, and Dr. Olalekan will be going through that shortly. Thank you very much for joining us. Over the next, we'll try and do it over the next 40 minutes, and then we'll take questions. Please, there's a tab for Q&A, so put your questions there. If you want to ask your question live, just raise your hand. There's an ability to raise your hand. When the time for question and answer comes, we'll pick you up and then we'll also answer. If you have questions related to this, asthma better, but if you have any other question related to any other topic, we'll also be able to answer some of them live here, especially in relation to internal medicine. We hope you enjoy it and that it benefits you and benefits your practice and your patients going forward. So Dr. Olalekan, over to you.
Okay, thank you, sir. Good afternoon, everybody.
Good afternoon.
Please, you have to allow me to share my screen, sir.
Okay. All right.
I'm still disabled.
Just a minute. Okay, go ahead. Yep, great.
Good afternoon, everybody.
You can go ahead. You can start.
Okay. Thank you very much, sir. Good afternoon, everybody. And we're all welcome to today's webinar. Today we'll be talking about asthma management. So we're just going to be giving a brief overview of the latest update on the management of asthma. I'm Olalekan Olaleye. So we're going to be going through the topic using this outline, and like I said, we will briefly go through so that we can have time for discussions. So as we all know that asthma is a chronic inflammatory disease of the airway, and the key things in asthma is we have chronic inflammation going on, hyperresponsiveness of the airway, leading to variable airway constriction and presenting with the typical symptoms listed. And these symptoms, they are reversible either spontaneously or with treatments. Those key points are important because we have to make sure that these features are important before we can conveniently make a diagnosis of asthma in our patients. The Global Initiative for Asthma 2020 simply put asthma as an heterogeneous disease that is characterized by chronic airway inflammation with the typical respiratory symptom and with the variability of the air flow limitation. So this is letting us know that in patients with asthma, the symptoms and the airway limitation or constriction is variable. So it changes in intensity, it also changes over time. So when you have a patient with a fixed airway obstruction or fixed airflow limitation, that patient might not likely be suffering from asthma. And worldwide, asthma affected over 300 million people, and the number is increasing. As we know, and is increasing. So also the prevalence. So also the prevalence of asthma. And unfortunately, asthma-related deaths and even prevalence has been on the rise, even in low and developing country, and is on the top 20 cause of number of years lived with this support. So it's a very big problem. And even in Nigeria, the prevalence of asthma is on the increase, like I said, due to increased smoking, pollution, and other social factors. All those are driving the prevalence of asthma in our environment. And looking at the prevalence of asthma in a nationwide study done by Ozo et al., looking at the national prevalence of asthma based on report or symptom of asthma, use of bronchodilator, and doctor diagnosed asthma. It was found that the prevalence of asthma in Nigeria is around 6.4%, with the highest prevalence found in Lagos. As you understand, due to the overcrowding, the pollution, the highest prevalence in Nigeria is found in Lagos, Nigeria, and the least is found in Ilorin in Nigeria. And all these points are in good control. And it was also found that most of the physicians don't really follow guidelines in the management of asthma as regards the use of controller medication, the use of reliever medication. So this is one of the reasons why we think we need to update our knowledge about the management of patients with asthma. Quickly, we all know that asthma is due to complex interaction between cells. There are a lot of asthma genes that have been identified, now coupled with some environmental factors in this. About the age, in the younger group, asthma is commoner in men.
There appears to be some problem with the sound, with the connection. Is it only happening to me or it's happening to other people? Dr. Officer, please can you help me check what's happening with his connection?
Okay, I'll check on it, sir.
All right, he's just hanging. It's like it's from his end. So just a minute, we'll sort it out now. It's normal Nigerian issue. So we've been talking about asthma, and then asthma is essentially a global disease, a heterogeneous disease affecting the airways. And Dr. Olalekan has been looking over the epidemiology and how it affects different regions based on the based on the presentation that are there. Dr. Olalekan, you're back on. Based on the prevalences that have been reported via several studies. So he'll just continue that. We'll talk about pathophysiology. Dr. Olalekan, we need to go back a couple of slides because we couldn't hear you for quite a while. For the first 5 minutes, we couldn't hear you.
I think I'm clear now. I think I'm clear now, sir.
Yeah, clearer, but it's still a little bit breaking up. Dr. Officer, please can you help with his internet?
Hello?
Yeah, I can hear you.
Okay, thank you very much. So let me start from the pathogenesis. Oh God.
Go ahead. We are hearing you.
Okay. So, like I said, it's a complex interaction between gene and the environment. And I was talking about the different environmental risk factor, the exposure to outdoor-indoor antigen, viral infection, exposure to some triggers at the workplace. And the hygiene hypothesis is trying to explain that exposure to infection from childhood help to restore the balance between the hepatitis cell type 1 and type 2. For those people that are exposed to infection early in life, the balance still towards the hepatitis cell 1 that produce the interleukin 2, which leads to cellular immunity. But for those development of allergic reaction. So other triggers include emotional stress, other morbidity. All this works together to result in bronchoconstriction and the other symptoms that we find in people with asthma. So when a susceptible person is exposed to all these factors, what happens is there is production of IgE. And when the IgE attached to mast cell, then there is production of histamine and all other factors that now result in bronchoconstriction, increase in mucus secretion, increase in capillary permeability, and tissue edema. So all this now leads to narrowing of the airway, edema of the other cells that are also implicated, eosinophil, macrophages, fibroblasts, and now all will result in airway narrowing, constriction of the smooth muscle, dilatation of the bronchial vessel, mucosal edema, and other inflammation. There's also damage of the airway cilia and hyperinflation. And Also, in the diagnosis, we talked about asthma being a reversible condition. But due to remodeling that also occurs in the airway, this damage may now become persistent. So for some group of patients with asthma, their airflow limitation and obstruction may no longer be a reversible thing due to airway remodeling. And for you to make a confident diagnosis of asthma, we need to have history, and we also need to establish the variability symptom and airflow limitation variability. So one, for us to confidently make a diagnosis of asthma, the symptoms must be present. Ideally, we should have more than one type of symptom, not just one symptom alone. We should have more symptoms. Then the symptoms also varies, like I talked about variability over time and in intensity. These symptoms are worse at night or early in the morning, and they are triggered by exercise, exposure to cold, and allergen. And symptoms may also be worse with like I talked about, especially when there's improvements in symptoms during the weekend or on vacation, then presence of a family history of asthma and other associated. I hope
Okay, please, just a minute. Let's change your internet connection.
Please,
give us.
Okay, sir.
Just to connect the internet connection, just give us 1 minute. Let us just connect. Let's change his internet source just to make sure that we will get a better picture. Just a minute. So sorry about that. These are some of the problems we experience in this part of the world. But for those of you watching from outside the country, just hang on a little. Those of us in Nigeria, we know, we understand, we may be understanding of what is happening. But just give us 1 minute, let's just change our internet source to another source and hope that it gets better. So Dr. Olalekan has been talking about the pathophysiology of asthma and epidemiology. We talked about where it is highest, especially most of the epidemiology has been reported and more in Lagos. Also how Ilorin has a relatively low reporting of asthma. And the pathophysiology, which essentially asthma is said to be a reversible. Dr. Olalekan, once you are ready, just let me know. Asthma is said to be reversible airflow limitation. However, the recurrent smooth muscle hypertrophy, mucous wall thickening, edema of the walls, which he has talked about in pathophysiology, essentially over time causes some people that have had asthma for a long time to have it no longer being as reversible as it was. In that case, their inhalers may not work as well, and then the asthma management has to be stepped up. We'll go later into management, but we have quite a number of questions that I'm going to be asking you so that we can gauge your participation and understanding. Dr. Olalekan, are you ready? Dr. Olalekan, are you ready? Okay, so essentially, the other things we talked about was diagnosis. And we said that diagnosis is one that has to be made using a combination of factors. Diagnosis, asthma is not one that diagnosis is made from a lab test or from one source. Asthma essentially is made, the diagnosis of asthma is made by putting together multiple forms of clinical evaluation. That starts from history. And so history is one of the most important things when making diagnosis of asthma. Then when you talk about history, we also look at the other components of the history, family history, what other things were there, what are the things what are the triggers, are the associated issues, and then what worsens the symptoms and what makes it better. Dr. Olalekan, are you ready? If you are ready, just let me know.
I'm back. Thank you.
Yeah, you're back. Okay, please go ahead. So Dr. Olalekan will continue.
Okay.
Please just go back 1 or 2 slides so that we can catch up. So sorry for the signal quality. Sir. Yes.
Sorry for the break in transmission. So we'll start again from the diagnosis. Like I said, we have 2 components which we need to make a good diagnosis. One is the history, and the 2 is to establish the variability in the airway obstruction. So the typical symptoms, the wheezing, shortness of breath, chest tightness, and cough. Like I said, we should have more than one of these symptoms before we make our diagnosis. For example, patient can not only be complaining of cough alone, and you make a diagnosis of asthma. Then the symptoms also vary over time and in intensity. It's worse at night and early part of the morning, and the history of the symptoms worsen after exposure to cold air, exercise, and the other allergen is also there. And the other associated history, the family history, the history of occupational exposure, and other comorbidities that make asthma worse. Example is rhinosinusitis, obesity, gastroesophageal reflux disease. All these are comorbidities that may be present in patients before we make diagnosis of asthma. And the second component is for us to be able to establish the variability in the airflow limitation. So we need to make sure that we establish that the airflow limitation also varies over time and in intensity. And this is where our spirometry and peak expiratory flow comes in. So the first thing we want to establish in making the diagnosis is to establish airflow limitation by assessing the first expiratory volume in 1 second and first vital capacity. We first of all need to look at this ratio, and once the ratio is low, less than 70%, we can say, okay, there is airflow limitation. Then number 2 now is to now establish the variability, whether there is improvement after the use of bronchodilator or not. So we'll give these patients a short-acting bronchodilator to use, and you assess these values again. So if there is an improvement of about 12% or 200 mils in the FEV1 after the use of bronchodilator, you can establish, okay, a positive bronchodilator reversibility test, which supports highly the diagnosis of asthma. Then also variability in peak expiratory flow. Then positive exercise challenge test. In this, what we find is after exercise, there is a fall in the FEV1 of the affected patients by about 10% from the baseline in adults. So this is another positive test. Then positive bronchial challenge test using either histamine or methacholine. So when you use this, what you also find is there is a fall of about 20% from baseline in the FEV1 after giving the patient either methacholine or histamine. Then if there is increase in lung function after 4 weeks of use of corticosteroids, corticosteroid is another way of establishing variability in the airflow limitation. So the greater the variation you find, the better the chance of making the diagnosis of asthma. So we look at the history and we look at the airflow limitation. You should be able to establish this before we can confidently make a diagnosis of asthma in our patient. And this is just showing us picture of peak flow meter and a patient having a spirometry done. So this graph is for one of our patients here that came with typical asthma symptoms that varies over time. And the patient was taken through spirometry. And sorry, I will just go to the interpretation. The interpretation says there's severe obstructive airflow defects. Then there's reversibility with bronchodilation with 38%, about 380 mils improvement after the use of bronchodilator, which strongly is in support of diagnosis of asthma. And the patient was commenced on appropriate therapy and the patient improved. Then using our peak flow meter, when you have an improvement of about 60 mil or 20% from the pre-bronchodilator results after the use of the bronchodilator suggests a diagnosis of asthma. And with your peak flow meter, we can also monitor the improvement of the patient, and we can also use it in assessing patients, especially those exposed to occupational allergy, so that when they are off work, you do their peak PEF and you repeat it when they are at work to see the difference. Then other importance of doing the spirometry is you are able to assess the severity of airflow limitation. You can establish the reversibility of airflow limitation. You can assess the management of these patients while they are on different type of bronchodilator. Then other tests, I talked about the bronchial provocation test using the methacholine histamine. We can do the allergen test by doing skin prick testing and measuring the IgE produced. Then we can measure the sputum eosinophil. And in other patients, we may need to actually differentiate between the dyspnea due to asthma and dyspnea due to other conditions like heart failure. So your echo comes into play. Estimation of B-natriuretic peptide also comes into play, which, if elevated, strongly is supportive of heart failure rather than asthma. So this is a table that we can go through, giving us different differential diagnosis of each of the symptoms mentioned. Like I said, if you have isolated symptom, you should think of something else rather than asthma. For example, patient with cough, sputum production, history of smoking, elderly patients, you should think of COPD. Patient with dry cough, persistent dry cough, you try and rule out possibility of angiotensin converting enzyme inhibitor induced cough and other stuff like that. So bronchiectasis, TB, I talked about heart failure. All these are close differential diagnoses that we have to rule out in our patients. Then just giving us a brief comparison between asthma and COPD, which is tightly related. So in asthma, the airflow obstruction is small. The airflow obstruction in COPD is less reversible compared to asthma. More airway inflammation in asthma, more mucus secretion in COPD, and other difference, as we can see later on this slide, so that we don't spend much time. We also talk about the possibility of a cough variant asthma. In this group of patients, the prominent symptom is cough, while they have less of breathlessness and chest tightness. But here, before you make the diagnosis, you have to establish the presence of airway hyperresponsiveness using the histamine provocative test of methacholine, and also assess the variability in the lung function. This must be established before you can say a patient has a cough variant asthma. Else, you have to look for other differential like I listed earlier. And now, having established your diagnosis, before you go into treatment, you have to assess the level of asthma control of the patients. And this is defined at the extent of the manifestation of symptoms you see in the patients that you are treating. And this has two components. You have to look at the symptoms and you have to look at the risk of future adverse effects in the patient. So looking at the symptoms, one, you have to determine the frequency of daytime symptoms the patient is having. How frequent is these symptoms? Cough, chest tightness, difficulty with breathing. How often? If a patient is having these symptoms more than twice in a week, the patient is having partly control or uncontrolled. If there is limitation in level of activity, if there are night symptoms, if there is frequent need for patient to use the reliever medication, then these are symptoms that are pointing to a patient that has a poor control of asthma or a severe form of asthma. Then looking at the other components that talks about the risk of future complication, that has to do with the number of exacerbation the patient is having, how good the lung function is on spirometry or peak exploratory flow. So all this you put together for you to know, okay, the level at which you are having your patient, and that is what is going to determine how you will start your patient on medication. Now, going to the treatment per se, what are the goals of your treatment? The goal of your treatment is you want to achieve good symptom control as much as possible. You want to make sure that the activity level of the patient is not affected, and you want to minimize the risk of exacerbation, risk of airflow limitation, and you want to avoid side effects from the medication you are going to use as much as possible. And so in GINA 2020, right from 2019, they now talk about personalized asthma care for each patient. And this involves, number one, good communication with the patient. You want to explain things to the patient in the language that is very clear to the patient. You want to explain the diagnosis, the pathophysiology, all the triggers, and other environmental factors that the patient needs to avoid. You want to bring the patient in so that the patient will be able to follow the care you want to give him. So you want to confirm the diagnosis, you want to assess the level of symptoms, you want to look at risk factors for future complication, you want to look at comorbidity. Is this patient obese? Is this patient having gastroesophageal reflux disease? Is this patient having sinusitis? Is this patient working in a place where he's exposed to allergen? Then you want to look at the goal of the patient. What is the target of the patient in relieving of his symptoms? So all this we have to come together before you now start prescribing your medication and teaching the patient how to use the medication you are going to give and how to avoid all the environmental allergy. Then you review your response. So this is the management cycle for personalized asthma care that GINA is talking about. And you have to look out for this point. What are the things that could make patient not to have a good control when you start treating? Number one is when your diagnosis is not correct. Like I said, we need to look at those symptoms and airflow limitation for us to make a correct diagnosis. Then incorrect choice of inhaler, we'll go to this shortly, and poor inhaler technique. That means at every visit, you need to tell the patient to demonstrate to you how the patient has been using the inhaler to assess the technique, whether the technique is good, whether the technique is poor or not. Then patient belief and adherence. And this is why we need to communicate with the patient very well so that they will understand the need for the medication you are giving, the avoidance of all the risk factors, and that will improve their adherence. Smoking, presence of comorbidity, and persistent exposure to agents are the other reason for poor asthma control. So, and other way to also assess the asthma control is to use questionnaires and other tests that have been validated by Global Initiative for Asthma. The one that is readily available with us is the asthma control test. And you want to ask all these questions at every visit when you see your patient. You want to know the frequency of the symptoms, the number of time the patient used reliever symptoms, nocturnal symptoms, limitation of activity, and you want to put this together in a score. When a patient has a score of less than 20, you know that the asthma control is poor, and you now need to go through all those domains again. Assess inhaler technique, assess your diagnosis, look out for environmental allergen, history of smoking, and other comorbidities that makes control poor. This is looking at the inhaler technique. We'll still demonstrate this during our comments at the end of my presentation. You want to ascertain, is the person using the inhaler correctly? So, and these are the steps. Before you use, remove the cap of the inhaler, shake. The patient should breathe out. Then put your inhaler in your mouth, close it tightly with your teeth, with your lips. Make sure the teeth is not in front. And as the patient is breathing in, the inhaler is activated, and the patient takes a deep breath for 10 seconds. Some authorities say breathe in for 5 seconds and hold your breath for 5 seconds. And after, the patient can now exhale. So you should assess this at every visit the patient made to the clinic. I'm now going to the treatment per se. The first thing that the Global Initiative for Asthma has made since 2019 is that the use of short-acting bronchodilator beta agonist, example salbutamol, only is no longer recommended for treatment of asthma, irrespective of the stage, because this has been found to be fraught with a lot of complications. Then the risk of exacerbation is very high, and also the risk of side effects is also very high. So from 2019, you should not give your patient only salbutamol inhaler as treatment for asthma, irrespective of the level of the symptom the patient is presenting with. So what is recommended now is for patients with very, very mild symptoms. Those are the ones in step 1 and step 2. It's either you give them a low dose inhaled corticosteroid and long-acting beta agonist on as needed basis, or you use a low dose inhaled corticosteroid along with short-acting beta agonist when the patient has symptoms. So if the patient has a mild symptom, this can be used on as needed basis, not just short-acting beta agonist alone, not salbutamol alone. So you can give the patient, like in our environment, fluticasone, salmeterol inhaler to use on as needed basis, or the patient can use inhaled corticosteroid inhaler anytime the patient has a need to use a salbutamol. Then another thing you can do is, for those that have more frequent symptoms, you can just place them on a daily dose of low dose inhaled corticosteroid, or as needed combination of inhaled corticosteroid and long-acting beta agonist. And long-acting beta agonist. And you can just step up based on the level of control the patient is having. Step 3 talked of patients that have partly control. Then step 4 and step 5 talked about patients that have poor control. So as you go up that ladder, you increase your dose of inhaled corticosteroid. Then you can now start adding other add-on. But common to all this is we need to continually check their inhaler technique, check exposure to environmental allergen, and also check the presence of other comorbidities that must be addressed for us to have a good control. So like I said, for their preferred controller medication, they should not use short-acting beta agonist alone. It's either they use inhaled corticosteroid or inhaled corticosteroid plus a long-acting beta agonist. So this slide also showed the same thing. And this is a table showing us the doses of the low dose, the medium dose, and the high dose inhaled corticosteroid, which we can use as a basis for prescription of this inhaler for our patients. So on this table, I just listed the common controller medication. Controller medication and medication that the patient needs to use to prevent symptoms. So it could be on as needed basis or on daily basis, depending on the level of severity of the patient's condition. So you have the inhaled glucocorticoid, examples, the budesonide, the fluticasone. You have the leukotriene modifier, example, the montelukast. Then your long-acting beta agonist, salmeterol, formoterol, and the rest. Then the reliever medications are used when the patient has symptom, has an attack. And the number one there is the short-acting beta agonist. Example is salbutamol. Then the oral corticosteroid comes into play, prednisolone or hydrocortisone. The short-acting anticholinergic, the hypertrophic bromide, and the others as listed with their mechanism of action. And so, and when you place your patient on medication, you need to monitor. And your monitoring is based on the two components I talked about earlier, as in talking about the symptom and the airflow limitation. So you want to assess your symptom. How often is the patient having night symptoms? How often is the patient using the reliever medication? So this is what is going to guide your treatment. So what's a measure of good control? For patients to have good control, the patient should have symptoms less than 2 times in a week. The patient's activity level should not be affected in any way. The patient should not have night symptoms. The patient should not have acute exacerbation. The lung function of the patient must be good. So this is a patient that has good control. And once you are able to maintain this level of control for about 3 months, you can now talk about stepping down the treatment of the patient. For example, if a patient has been on step 4 level of treatment for 3 months and you'll be able to achieve good control, then you can consider stepping the patient down to step 3. Then after 3 months of step 3, the patient is doing well, you can step down accordingly like that. But for patients with frequent exacerbation, patients with severe airflow limitation, patients with positive bronchodilator reversibility, it is not advisable to step this patient down on their current level of medication, despite the fact that you are achieving good control. And the reason why we want to step down once you achieve good control is, like I said, one of the goals is to make sure that we avoid side effects from medication as much as possible. So you want the patient to be on medication that will not give the patient any side effect on a long-term basis. And that is why we talk about stepping down once you can maintain a good control and in the absence of all those features of severe airflow limitation and frequent exacerbation. Then briefly talking about exacerbation. What we mean about exacerbation is once there's a change from the patient's usual status level. A patient that is on stage 2 for a long time, just within days or weeks, starts to have more frequent symptom, more night symptom, limitation of symptom, then we can say, okay, this patient is having an acute exacerbation. So there's progressive increase in all the symptoms, and there's a change in the patient's usual status, and this will require you to make some changes in treatment. So this is defined as acute exacerbation, and listed on these slides are different triggers, which could be infection, exposure to allergen, both indoor and outdoor, poor drug adherence to inhaled corticosteroid. Some patients react, so some to some particles in their food. And so these are the common things that we should look out for in the patient having an acute exacerbation. They should be addressed, because if you don't address them, you won't achieve results. And exacerbation can be mild, can be moderate, and can be severe. And the features of each level of exacerbation is listed in the box. But let me just quickly talk about those with severe exacerbation. These are patients that talk in words. They cannot complete a sentence at a breath. The respiratory rate is very high. They have tachycardia greater than 120. The peak expiratory flow is less than 50%. Then they have low oxygen saturation, less than 90%. So this is the patient that has a severe form of exacerbation and should be treated as such with the use of your corticosteroid. You want to quickly administer your short-acting beta agonist via a nebulizer, or you can still use the meter-dose inhaler with the aid of a spacer. Then you need to give this patient steroid. It could be oral corticosteroid. It could also be IV. You can make use of tap prednisolone or use IV ibuprofen. Both of them work equally. Then if the SpO2 is low, like I said, less than 90%, the patient needs to be on oxygen to bring the saturation up to between 93 and 95%. And you need to assess for all those triggers that need to be treated. And once the patient gets better from the exacerbation, you assess inhaler technique, you assess adherence, and you address all those issues. Then patients that has features that looks like asthma and look as COPD. So you look at the symptoms that is most prominent, and that is what is going to inform what you're going to treat in this patient. For those that is likely to be asthma, the variability of the symptoms, the variability in the airflow limitation, you need to establish that, and you need to treat the patient as someone with asthma. For those that has features that is more in keeping with COPD, sputum production, fixed airflow limitation, elderly or advanced age, history of smoking, that is more in keeping with COPD, and you all need to follow the gold guideline to manage them. But there are some that has mixed picture that is not clear. It is advisable that this group of patients be treated like someone with asthma, with use of your inhaled corticosteroid and long-acting beta agonists. And briefly, before we close, talking about COVID-19 as asthma, as we know that COVID-19 mainly presents with breathing difficulty, which could be one, confusing in patients with asthma. Then two, also some caution needs to be taken in patients with asthma. And as at April this year, what GINA advised is patients with asthma should just continue their medication. They should not stop their inhaled corticosteroid. They should not stop their long-acting beta agonist. They should not stop their short-acting beta agonist. Just continue present level of treatment. Then we should avoid nebulization as much as possible because of the aerosol that is generated during the procedure. We should try and avoid this as much as possible when there's acute exacerbation. Then, in patients with you are suspecting COVID-19, avoid spirometry as much as possible. Use other form, look at the symptoms and other things to make your symptom. And the patient should follow their treatment plan. There's no need to change anything that is working for the patient, whether the patient has COVID or you are suspecting COVID. But like I said, caution should be exercised in spirometry, in nebulization for this group of patients. So thank you for listening. Sorry for the break due to the technical issues, and The presentation is mainly from the Global Initiative for Asthma report for 2020. So thank you for listening, and if there is time, we can go through some case studies. Hello,
I
sir.
think we can go through some case studies. Let's go through some case studies.
Okay, sir.
Let's go through a couple of case studies.
Okay, sir. So we just look through some case study. Here we have a 20-year-old lady living with her relatives that are all heavy smokers. And she's been diagnosed from age 10. And here, she was only given a short-acting beta agonist. And she was given instruction on how to use the inhaler. So on follow-up, it was found that she was not doing well because she's been having frequent symptoms. So the first thing noticed there is that this patient has only been on short-acting beta agonist alone. And like I said, according to GINA, it is no longer advisable to give your patient only short-acting beta agonist, even if the patient is having infrequent symptoms. So the use of inhaled corticosteroid is cut across every level of asthma control. So there should be a controller added to the short-acting beta agonist that this patient is using, and the patient's relatives should also be advised to stop smoking so that the patient is no longer exposed to indoor pollution. So those measures were done, but the patient is still complaining of persistent cough and frequent attack. So what do you do next? One, you need to assess our inhaler technique and establish adherence. So you need to ask her to demonstrate. And it was actually found that this patient has not been using an inhaler correctly. And this was corrected by showing a good demonstration of how to use the inhaler. And the family member were also advised to stop smoking. And another thing that was also identified in this patient is that she's afraid about using her inhaler in public. And that is one of the reasons why I said good communication with the patient is very important, so that the patient can be confident. The patient will not have this stigma of having to use an inhaler maybe in the presence of people or elsewhere. So we need to communicate with this patient very well and educate her on the need for her to adhere to her inhaler and for her to use the inhaler correctly. So how will you convince her? So we need to educate her. And after 3 weeks, she was still having poor control. So now that means we now have to step up from where we are. And this has to do with the monitoring that I talked about. Once you assess the symptom and the patient is not feeling well, then you need to step up. If the patient has been on as needed inhaled corticosteroid and long-acting beta agonist, you may need to increase it to daily, a low-dose inhaled corticosteroid and long-acting beta agonist. If the patient has been on a daily low-dose inhaled corticosteroid and long-acting beta agonist, you may need to move up to a medium dose, and you may need to add other medication along with it or switch to alternative reliever medication while looking at exposure to other environmental allergens, addressing comorbidities that could make control poor. So those are the things that we need to do for this patient for us to have a good control. So when we use schedule a follow-up appointment, so you need to see your patient depending on the level of symptoms within 1 to 3 months at least, so that you'll be able to assess their level of control. And once they have good level of control, you can space out your next visit. And when all those things was done, at our next visit, the symptoms improved and the asthma appeared to be under control. So what should be your next course of action? At that level, you need to maintain and monitor the patient for another 3 months to make sure that the control is well established and maintained. Then after the 3 months, you assess the patient, you look at the symptoms, you do your PEF or your spirometry. If you are satisfied, you may attempt to step down the patient's treatment and assess. And when you step down, you need to give a short notice for you to be able to assess what you have done. You don't step down and ask the patient to go away for 3 to 6 months. If you are doing any change, either stepping down or stepping up, you need to give a short appointment to assess the change that you have made. Then quickly looking at this second case study, we have a 32-year-old man, non-smoker, fit, is undergoing stress emotionally at work and has been diagnosed since childhood. Is on both a reliever medication, a short-acting beta agonist, and a control lab medication, which is very good. But his asthma is not improving. So what do we need to do? The first thing, we need to assess for triggers. Is he exposed to anything at work, at home? Check his inhaler technique. Look for comorbidities. This must be done at every visit so that we'll be able to assess what we're doing. And furthermore, an asthma control test was done for this patient using the questionnaire that I talked about, and he has less than 20 when the scores was put together, meaning that his asthma has been poorly controlled since the last time he came. What that was done is the inhaler technique was checked, adherence was checked, then his controller medication was increased a bit, and the work stress was also addressed. And by the time he came for the next visitation, there was improvement in his level of control. So we need to assess symptoms control. You may need to adjust your level of treatment based on the response. And like I said, we should always look for other comorbidity and other factors that could affect control apart from the use of drugs and making a right diagnosis. Then finally, the third guest we have is a 21-year-old lady with poor control. But what was found here is, due to COVID and the lockdown, she's been indoor, likely exposure to indoor pollution. She's gaining weight, like we said. Obesity is another comorbidity that makes control poor. And also, she's only taking a reliever agent. Seretide is combination of fluticasone and salmeterol at a low dose. No use of the guests have not been using beta agonists at all. Then another thing that was also discovered was there's this episode of regular blocked nose and catarrh, and it was actually found that the guest actually had a rhinosinusitis, which, like I said, is another cofactor that makes control difficult. So what did we advise the guests to do? Improve hygiene, to clean the room, to avoid all those indoor irritants. Then ceiling fan, which could have gathered dust and be causing some level of discomfort. Then we increased from the low dose inhaled corticosteroid and long-acting beta agonist that she's using. We stepped up to medium dose, and we added short-acting beta agonist. And we also gave her intranasal steroid fluticasone for the rhinosinusitis. And we just gave her a short notice. This guest was seen early this week, so we're expecting her next week to assess the efficacy of the steps we have taken. So I've just put these 3 case studies for us to know how to address on visit by visit, what to do for the patient, what to assess, what to do, and how to address cases as they come up. Thank you very much, and thank you for listening. Hello, sir.
All right, thank you very much. So we'll take questions. If you have a question you want to speak orally, you can just raise your hand and I will call you up, I will unmute you, and otherwise we'll just take questions. Dr. Roger, do you have any additions to make? Dr. Roger? Dr. Roger is a consultant care physician. Do you have any contribution to make? We're not hearing you very well.
Very much. I'm quite impressed. Can you hear me?
No, we're not hearing you. You are slurring as if there's a stroke. You are slurring as if you have a stroke. You need to check your internet connection. You are slurring as if you are having a stroke. Hopefully you are not. Please check your internet connection.
Hello, can you hear me?
Perfect.
Can you hear
Go
me?
ahead. Yes, I can hear you perfectly. Go ahead.
Perfectly. Yes, I was saying that I was quite impressed with Dr. Olalekan's presentation. It was quite a detailed presentation. I'm sure everybody's well aware that asthma is a very complicated topic and it's very wide-reaching. There's so many aspects to it. But I think Dr. Olalekan has done a good job of actually focusing us on some of the important things, particularly concerning actual management of patients, which I think is the focus that most people will have. The management of patients, how to actually accurately make a diagnosis, and what to do in cases where patients are getting better and you want to decide whether to move them from one drug to the other. And I think that was quite impressive. The only things I want to add at this point, I'm sure there will be plenty of questions, but the thing I'd like to mention now is that people shouldn't hesitate to seek to refer patients for secondary care. I see a lot of patients that somebody has managed them for asthma or made a diagnosis for asthma, but the drugs that they're using is either maybe they're on oral medications only, or they're on only inhaler. They've never really had very good comprehensive asthma management. Most of these patients, they will do well with maybe even if it's just a single visit, especially just kind of package the care and then follow up subsequently with the primary doctor or primary care doctor. And then afterwards, if there's a problem or they're having poor control, you don't need to always take all the burden on yourself. Don't hesitate to seek secondary care. That's number one. And number two, as much as possible, two things: a high index of suspicion for asthma in patients with recurrent respiratory complaints, and two, patients you should, as much as possible, try and get patients to be, okay. A lot of times people are just manage their symptoms. Asthma patients, they tend to underestimate them. And they just keep managing it. Oh, they use their inhaler, they use their inhaler, and they're using it frequently. It's important to, like Dr. Olalekan mentioned, that you should have either a way of assessing patients' control, the asthma control test, for instance, just to know that are these patients actually doing well? A lot of people activity, which is what GINA, as much as patients are really doing well on whatever regimen they're on. Not just that they're not complaining to you, but are they really doing well? That's very important. Thank you. Hello? I hope everybody will be able to hear what I said.
Thank you very much. So we have quite a number of questions. So we're taking them. There are quite plenty. So we're taking them one by one. how do we establish a diagnosis of asthma in children? If asthma is suspected in children, what medication can be given to prevent progression? Okay, how do we establish a diagnosis of asthma in children? And if it is suspected in children, what medication can be given to prevent progression? Okay, should we yes, we heard what you said. You want to answer the question? Hello, Dr. Iroja.
Yes, I would like to answer the question. So, asthma in children, asthma in children, it can be a bit tricky to diagnose, especially in children under 5 years of age. Okay, so the best thing, I mean, for older children, a lot of them can be diagnosed the same way you diagnose adults. I've seen children of 5, 6 doing spirometry perfectly. So you can diagnose children of that age and above with normal spirometry. You can even do metacolin challenge for children as well, right? Then you can also try some of the other things like fractional sputum eosinophilia, but these are not diagnostic of asthma. So for children under 5, typically clinically, that's how you diagnose them. You can watch them and have a high suspicion and watch as they grow older, but usually you diagnose them clinically. Then, I mean, if you're in a more technology.
Okay, I was not hearing him as much. So essentially for children, he said that I am diagnosed in children and which we also practice, especially if the child is able to. Great, okay, I was not hearing before. You
okay, I said that. Okay, I don't know if you heard what I said about management and in diagnosis that you can
you said about advanced settings, about something technology.
Yes, impulse oscillometry. It's new-ish, not really that new, but it's new-ish and it's not really available around here. But it's independent of effort. So old people can do it, children can do it. You don't need other stress or spirometry. Reversing the spirometry done, it's a lot of effort that's required. But for this impulse oscillometry, it's not much effort that's required. So it can be used. And then for the treatment, important things to note for treatment of asthma in children is that you do not give long-acting beta-2 agonists alone. If you're going to use it, you don't use it as quickly as you use it in adults. You use it maybe when you've tried maybe 3 or 4 steps. You might now decide to add a long-acting beta-2 agonist, but it must always be added with an inhaled corticosteroid. Okay, so it's not the first line. But other than that, you can use similar drugs that you use in adults. You can use inhaled corticosteroids, you can use short-acting beta-2 agonists, you can use leukotriene receptor antagonists, and so on. I think I hope that's all the questions for that.
Yeah,
I think I answered everything.
That answers the question. Somebody said, how do you prevent anticipated side effects? I think that one is straightforward. Essentially, you ask your patients when they use their corticosteroid inhalers to rinse their mouth afterwards. That's all. For most of the patients, that should typically suffice. Most patients that get it from this are those that just use it and then continue. So you just ask the patients rinse their mouth after use. Okay, so I think that's good. Dr. Stanley says, why is there no synergy between pulmonologists and air pollution scientists? Because they are working together will help asthma patients. So those are advocacy questions, and it's quite important. However, as Cardiocare hospital and as specialists, we are doing the part that we can do. Maybe one of us, I hope one of the people that are attending this seminar will become a politician and probably can help us push some of these things further. But you are in Nigeria.
Well, just a quick note on that.
Yes.
Just a quick note on that. Actually, they are working, like the Nigerian Thoracic Society works with air pollution scientists. It's a thing that's happening, especially in South where there's a lot of gas playing. There's a lot. In fact, I remember the last conference the 20 years in Abuja. They talk full thing. They are very much not as loud as people are expecting.
So the Nigerian Thoracic Society actually has been working with, although I know that they have been working mainly with the bigger companies, the bigger factories and the bigger oil companies to help. And then there have been some extra taxes that have been put. But some of those questions are a little bit political. Yeah, but the Nigerian Thoracic Society has been doing a lot of work. Actually, I know about that on the ground. It's not as publicized as we'll have liked, but just like the Nigerian Thoracic Society also does some work on the ground. Dr. Iroja, your sound is going on and off. Dr. Olalekan, you can continue the other questions.
Okay. There's a question here about pregnancy and asthma. So, pregnant patients with asthma needs to continue their medication. There's always this fear about the effect of corticosteroid bronchodilator on the fetus. The effect is even worse when the patient has poor control. So a pregnant patient should continue with their medication during pregnancy, during labor, post-delivery. Then pregnancy is another stage in which you don't need to step down your medication, even if a patient has good control. Just maintain what you are doing for that period of pregnancy and monitor frequently, control, and lung function. But the patient needs to use their medication.
Yeah, also remember that if you have a patient that is very poorly controlled asthma and having issues, don't forget to seek for help. That the physician comes in early so that you don't start struggling later on. So that's quite important. Maimuna Kasim, I'm going to allow you to talk. Maimuna Kasim, your hand has been raised. You can go ahead with your question. Just unmute yourself and talk. Maimuna Kasim. Maimuna Kasim, you have a question? Or your hand was raised mistakenly? Okay, maybe it was a mistake. All right, so Shehu Danjuma, you have a question? I can see your hand was raised. Shehu Danjuma, do you have a question? Okay, so whenever they are ready, they can just start talking. Okay, another question from Dr. Nweke Sandra says, what do you do with patients?
Hello, good afternoon.
Okay, good afternoon, Shehu Danjuma. You can go ahead with your question.
Good afternoon, sir.
Good afternoon.
I want to thank the presenter. The presentation was precise. The first question goes like this. In the pathophysiology he describes, he has not mentioned about status asthmaticus, because we need to understand and then we differentiate, because their mode of treatment also differs. So can he also expatiate when does this becomes a status epilepticus? The second question, in a multi-setup like this, like Limi Hospital, where we have a lot of field, if a patient is going for surgery and is a non-asthmatic patient, what are the precise things we put in mind when preparing this patient going for surgery? And then thirdly, my question is, in this pandemic era we have, how do we differentiate, or what are the differential between COVID-19 and asthmatic patient? Thank you, sir.
Thank you very much. Now I recognize your voice. That is Mr. Shehu Danjuma. He's an anesthetic nurse. So he's quite worried about surgery and asthma. And also, he also helps to intubate patients quick when they have acute severe asthma. So he talked about some aspects of acute severe asthma. So what has happened actually is that our previous presentations have been so long, and so we've tried to shorten most of them. So we've tried to focus on what we think are the major things that people have. So that's why we did not go as long as, in fact, we cut out a lot of slides. Okay, so Dr. Olalekan, can you help answer the questions. He asked 3 questions. Patients going for surgery that have asthma, what they can do. Number 2, acute severe asthma. So the name status asthmaticus has actually changed. So acute severe asthma is the more appropriate terminology.
Yeah.
And then his third question was
the difference between COVID-19.
Okay.
Okay. So
differential between COVID-19 asthmatic attack.
Okay. So COVID-19 and asthma. How do you, let me just shoot away with COVID-19. First is that you cannot differentiate. So let me just put that one there. You must assume that everybody that comes has COVID. So I think that is a valid assumption. Assume that everybody, especially if you're in Nigeria, where there's limited testing ability, there's limited critical care facility, assume that everybody has COVID. If they are not breathing well, further assume that it is COVID. So in this era, so after COVID, normal, but in this era, I think that's a good thing to add. I just need to add that. Dr. Olalekan, please go ahead.
Okay, thank you very much. So the same thing I want to say that assume everyone present to you with difficulty with breathing for now as COVID, because like I said, you don't even have that honor of doing a spirometry or anything. So it is better to assume the person has COVID, test for COVID first. And when the patient is not positive, then you can now undergo all the other tests. Then with surgery, if it is an elective surgery, you should make sure that the patient has a good asthma control with all the treatment plan we've talked about before you go into surgery, using all the normal medications. But if it's an emergency, you need to assess the risk of airflow problem with the risk of surgery you're going to. If you can still buy time, try and achieve good control as much as possible, because though surgery has not been found to increase exacerbation as a cause of exacerbation, but if there is bronchoconstriction during surgery, it could be fatal. So the key is to try as much as possible to get a good asthma control, if possible, before your surgery. Then the use of your steroid, either IV or oral, nebulized, short-acting beta agonist can also be used. The normal will be used for other patients. But try and achieve control as much as possible is the key for patients going to surgery. There is nothing especially that is going to change. And for status asthmaticus, it's better you treat them in ICU as a patient with a life-threatening or severe form of acute severe asthma, and manage them, continuous vital signs monitoring, use of bronchodilator, control of triggers, treatment of infection, oxygen, and I believe our patients will do well.
Dr. Eroja, you have something to say? I can see your hand is raised. Just unmute yourself, Dr. Eroja. Okay. Mr. Danjuma, thank you very much for your questions. So, like we have said, now if the patient is also going for surgery, make sure you go ahead, please. We're not hearing you before. Dr. Eroja, you can go ahead.
A few comments to make. First of all, some of the anesthetic agents actually have a bronchodilatory effect. So if you have a patient with asthma, you can choose some particular anesthetic agents which might help with bronchodilation, such as isoflurane. So that can help with maintenance of anesthesia. Okay. Then secondly, I mean, the worry would be some of the procedures for surgery, like maybe you're intubating, you can also trigger bronchospasm. But don't forget that if you end up intubating a patient, I mean, you're already inside the airway, you can you can give the patient any of the necessary bronchodilators that you need to give, even intraoral. So there are some considerations to make. The anesthetists are usually well versed in the precautions for managing patients with asthma. After all, if a patient's asthma is bad enough, they will end up in the ICU with the anesthetic. So there are a few things that they can do. You can give them bronchodilators via the anesthetic machine if that's in use, or if the patient is under maybe a local anesthesia or regional block and requires treatment for bronchoconstriction, they can be given nebulizer right in the theater. So there are a few considerations to make. That's why it's important to have a history before you go into theater. And like Dr. Olalekan said, it's important to also, as much as possible, achieve control before surgery.
Okay, great. Thank you very much, Dr. Iroja. Dr. Iroja, thank you so much for that question. Now, there are some more questions. So, Dr. Iroja, Dr. Olalekan, please get ready to shoot. It says, are there contraindications to use of LABA in pediatric age groups? I think he already answered that to an extent, but he talked about it rather in his remarks. So, are there contraindications to use of LABA in pediatric age groups for the management of asthma? And number two, does oral short-acting, that's salbutamol, find usefulness in the management of asthma? Okay.
Well, I answered earlier a little bit.
Yeah.
For LABA, lots of studies have shown that you have to use it with care in the pediatric age group. There was a study of over 26,000 people that showed a small but significant increase in asthma-related problems when you give LABA, especially LABA alone. So you can never give LABA alone in pediatrics. You have to give LABA with inhaled corticosteroid. And it's not usually your first line. It's not even your second line, okay? But it is useful in moderate to severe asthma, moderate to severe persistent asthma. So you can use it, but you have to be more careful with it. Then for the use of, but when you can go ahead and use oral short-acting beta-2 agents, especially for instance in elderly that you have trouble maintaining the use of inhaled bronchodilators, it is discouraged because the dose of oral is significantly higher than that of inhaled bronchodilators, and there's more likelihood for side effects. But resource-poor areas where there's poverty or other limiting factors to the use of inhaled agents, you can use it. So the indications for use are very narrow, but it's possible to use them. Okay.
So essentially, if you are in Abuja in the good hospital, you should hardly be giving oral salbutamol. So please, I've been seeing that kind of thing on a lot of patients. They're not well controlled. They have been taking salbutamol for years. You know, that is not correct. And that's one of the things that we want to correct with the presentation. So oral salbutamol has a role, but it's very, very limited, if at all. So please, we need to stop that as much as possible. Don't forget that oral salbutamol has other effects on the heart, which may be negative. Okay, so that should be done cautiously or not at all, as much as possible. Wake Sandra, so what do you do in patients that have poor control, but they are developing Cushing's syndrome on oral steroids? So, Dr. Sandra, typically, Dr. Olalekan talked about the steps in management on how to upgrade the management. Typically, you should not rush to oral steroids early. You should have gone stepwise with your inhaled corticosteroids together with long-acting beta agonist LABA, and then you now step up and step up. So before you get to oral steroids, a long while you have gotten there. Okay, so having gone all the way while the patient was still not getting better, and now is on oral steroids and developing side effects from oral steroids, despite your inhaled steroids, despite your inhaled LABA, despite your inhaled short-acting, your SABA, now on oral steroids and still having poor control with Cushing's syndrome-like features. There are several things that you need to do. One of them is that you need to go and re-examine your diagnosis. Number one, are you treating asthma? You need to start from there. Is it heart failure? Is there a chest infection? Are there other things? So you need to re-examine your diagnosis. Then at this point in time, I will say that a specialist should come in. You should refer to a specialist so that other agents can be put into consideration. Now, there are other agents that we have not measured on, antihistamines, other things that need to be put into place. Number 3, you need to check inhaler technique. Number 4, you need to check precipitants. Sometimes patients are living or working in conditions where they are exposed to precipitants consistently. The right approach is not to continuously be increasing the dose until you get to oral steroids and the patient is developing Cushing syndrome. That will only make things worse. So that should not be the way we should go. Okay, I hope that I've answered your question. So the next question is from Dr. Odiaka. He says, what is the role in today's management of aminophylline as it is still presently used in low-resource hospitals? What is the role of aminophylline? So Dr. Olalekan, Dr. Iruja, Dr. Ofisoye, what's the role of aminophylline in management of asthma? I've seen it so many times. What is the role of aminophylline? Okay.
Let me just say one quick word. Aminophylline can still be used, but everybody has to be aware that it is not a safe drug, right? If you don't have anything else, fine, but it's not very safe. There are many alternatives to aminophylline. Okay? Resources with care. Okay, I think you should use with monitoring and so on, so you can see how we've misused it. Dr. Olalekan, there's another comment.
I would say maybe if you don't have other options and you are left alone with the aminophylline, you can still use it, but since there are better drugs that are readily available, your short-acting beta agonists, your steroid, I think we should be wary of using aminophylline like Dr. Yoda.
Okay, so I will just add to them and say, please and please and please, no aminophylline in modern day medicine as much as is humanly possible. I doubt you see it in any medical textbook anymore. Yes, it can be used. If you have no option, it can be used. But as much as possible, avoid aminophylline in patients. There are several reasons. The cardiac arrhythmias are many and can be idiosyncratic. Whether you give it slowly or you give it whatever, or you give it just a small dose, the patient can actually die from that aminophylline. If you absolutely have to use aminophylline, make sure you do it in an ICU setting. Make sure that you have support from a specialist to do so. Please do not use aminophylline without continuous monitoring. And so you have a continuous monitoring ECG, which means that you can actually see the ECG, which means that you can actually read the ECG and know when a problem is happening. You should have continuous monitoring of SpO2, of oxygen saturation in the blood. You should have continuous monitoring of pulse and blood pressure. Please and please, as much as possible, except you are absolutely in any way, and even if you are in any place in Nigeria, for now, you can still make sure that your clinic has some agents to do proper management so that you have them on ground. Please and please, as much as possible, aminophylline should not be used. There are a lot of doctors that are using it. I know it was, when I was growing up, aminophylline was the, but in modern day age, they have very, very little role to play. And if you're using them, be very, very cautious. It's extremely deadly. Okay, somebody said, can you demonstrate the right use of seretide? Dr. Martin Ejimofo said, can you demonstrate the right use of seretide? Do you have any drug there? So let me see. If I do now, I've come along. I have something that looks like it. So let's assume this is seretide, right? So for seretide, you just press, there is a lever there, you press the lever down, and as you press the lever down, the patient is asked to breathe out, breathe in, put it in the mouth, cover completely all the sides, and then take a deep breath in. So take a deep breath in, hold their breath for at least 15 to 20 seconds, up to 30 seconds, and slowly release their breath. So they press the lever down, they open the inhaler, so just open it. They press the lever down, put their mouth wrapped, before they put their mouth, take a deep breath out and breathe out completely. Then put their mouth wrapped in and then take a long deep breath. Hold their breath for some seconds, 20, 30 seconds, and then gradually release the breath. So essentially that is how sanitize should be used. For you as a doctor, anytime a patient comes in, you must take time to check inhaler technique and to reteach it. So you must know it yourself. Okay, I hope that I'll be able to answer your question, Martin. If you're not fully convinced, just let me send down to the pharmacy to get one so that I can demonstrate it. Although that will waste a full dose of sanitizer, but I'm sure we can do with that for us. Somebody is asking about if patient has occupational asthma and cannot change jobs in an environment like ours, where jobs can be hard to get, what can be done? Physicians cannot solve the problems. Dr. Olalekan, let's see what can you do for someone that cannot change jobs?
Thank you very much. Based on the guideline, and maybe depending on the severity of the asthma the patient is having, avoidance or removal from the sites of the irritant is compulsory, is a major part of the treatment. If it's a mild asthma, maybe avoidance or maybe changing, maybe departments might help. But for patients with severe symptoms, you need to remove from that site. Irrespective of the other medical management you use, avoidance of the irritant, as long as the person is exposed to that allergen, there will never be a good control. So like you said, the physician cannot solve all the problem. So,
sorry, there's an addendum.
Yeah, there is an addendum. You can use a respirator. Doctor, I mean, you can use a respirator. Doctor, yeah?
Dr. Lally, yes, that's the addendum. You can use a respirator, right? In cases where it's absolutely necessary that you are there and there's no alternative, you can use a respirator. And that's what those N95s, there are many of them for construction workers and whatnot. They are very useful. So it's possible to use them, but you have to use them constantly. So it's not very easy either. So there are different types of respirators, but I mean, those are alternatives.
Those fancy masks that the Presidential Task Force is wearing and talking about this thing. Before all of this, that's what most people were using them for. Using them on construction sites, using them in factories to reduce all of those things. So when COVID is over, the mask will come down to 1,000 naira or whatever. It is very cheap. And those kind of patients should have them readily to use on work sites. Ideally, also, such factories are supposed to test their workers yearly. Spirometry, and maybe also to remember that we have done for a number of factories in the past where we do spirometry for large groups of workers to find out the people that have problems, and then they either relocate them or they institute certain mechanisms like giving them respirators throughout their work environment. Okay, so Dr. Sandra, and that's what we'll do. For a pregnant woman having acute exacerbation of asthma, is it acceptable to give salbutamol, knowing that it also acts as a tocolytic? Dr. Olalekan?
Yes, like I said, the patient needs all the medication, both the steroid and the beta agonists. And since you're using either maybe an inhaled salbutamol or maybe through the nebulizer or the metered-dose inhaler, the systemic effect is so less to the extent that you get the tocolytic effect from the amount you are given. So it is highly indicated. Because like I said, poor control even have bad filter outcome than not treating the asthma itself.
Okay, We have somebody asking that, okay, so essentially, and even in addition to what he has said, even when the patient takes inhaled salbutamol, it's not the absorption into the bloodstream. I don't think is high enough. The problem are the people that are giving tablets as treatment. So like we said earlier, please, as much as possible, reduce. It has a very minimal, if at all, any role at all. So if you have salbutamol in your pharmacy, you should be keeping it for tuberculosis, not asthma, or for other things, but not necessarily for asthma. So except that a person is taking oral tablets salbutamol, which in my mind has little to no place in current management of asthma, you should not be taking, and that's the kind of one that will cause problem in terms of tuberculosis or affecting pregnancy. So that should not be a place, Dr. George. Okay, Dr. Kasim Memuna says, what is the treatment of cough variant asthma? What is the treatment of cough variant asthma?
Okay,
Okay.
thank you.
Okay, Dr. Olalekan, you can go ahead.
Okay.
Okay, I just want to say that before you settle for that diagnosis, make sure that you are not dealing with something else. Like I said, the hyper-responsiveness should be established, the lung function test should be established, and it's going to be treated the same way you treat the other form of asthma. But the question is, their response to inhaled corticosteroid might not be as good as the allergic type of asthma, but you still treat them the same way. So I don't know if Dr. Eroja has any additions.
The response is not as good as with normal asthma, but inhaled corticosteroid is actually the mainstay. The short-acting beta-2 agonist, in fact, like you said, it's the same treatment, but the mainstay is inhaled corticosteroids. I mean, it might not be as dramatic as with regular asthma, but that's the mainstay of treatment.
Okay, somebody asked about asthma action plan. Can you throw more light on the term asthma action plan? Dr. Charles Odidi asked, can you throw more light on the term asthma action plan?
Okay, sir. So for each patient, there has to be an action plan jointly written by the physician and the patients, telling the patients, at least you can give some instruction, okay, as per what the goal is, what the treatment is, for the patient to personally assess the level of control and what to do even before the patient presents to you at the clinic. So you need to have something like that that the patient can understand and can follow. So the patient can also self-monitor. You put there things the patient needs to avoid in the environment, the present level of medication, and the possible adjustment, whether upward or downward on the scale based on the symptoms control. So that is what is really the action plan is really about.
Okay, I want to add something to that.
Go ahead.
I want to add something to that. In the modern world, all patients should have a peak flow meter. All patients with asthma, like diabetics, have a glucometer. All patients should have a peak flow meter. So with the peak flow meter, that's an easy way to actually work with the asthma action plan, like Dr. Olalekan said. So you have the peak flow meter. Patients are told that, oh, when your peak flow is like this, this is what you do. When it gets to this level, this is what you do. And then at a certain point in time, when it's gotten to this level, you can now come to the hospital. So before the patient even gets to the hospital, he has some leeway of things to do first. And then when he gets to a level that he cannot manage, and objectively, that's what you can use the peak flow meter for, he can now go to the hospital. So the patient should be aware of things he needs to do and the symptoms and signs, and then a peak flow meter. Okay?
Okay, so I think we have answered most of them. Somebody asked for younger children who may never to use inhaled bronchodilator properly, what then is recommended? I think somebody else has answered. Dr. Wimago has answered, say we use a spacer device. So you can,
Yes.
most places you can get a special device, and I mean, in our clinics are there in the pharmacy. So a special device essentially allows the child to breathe when it is puffed into it. And then you can also make one. So you can make a special device using a swan water bottle. That's what we used to use when I was in a town I don't want to mention on air. That's what we used to use before. You use a bottle and then you create it so that the person can use. You cut a hole at one end, you puff the inhaler into the bottle at the other end, well sealed, and at the other end, the person is just breathing in and out, and the child is able to get it. Or a special device with a mask. You just put on the child's face, it has some space, you puff your inhaler into the space, and then the child is breathing through the mask and it gradually breathes it on. Okay, so that's one possibility that can be used. Okay, also now there are a lot of home nebulizers that are available that a lot of patients already have, and they can also use at home sometimes before they even get to the hospital. So that is also an option that can be used. In children less than 5 years, what's the first line of treatment? Dr. Olaleken says in children less than 5 years, what's the first line of treatment?
It's a short-acting beta agonist. That's the first line of treatment. So
Okay,
then others can now be added with time, but short-acting beta agonist is the first line in children.
Okay, so Dr. Ogundumade, sorry, I didn't pronounce your name well, sorry. Can you please address seasonal variations of asthma? Can you please address seasonal variations of asthma?
We talked about changing weather, exposure to cold season, then seasonal change in the pollens and other allergens. Those are the things that usually result in the seasonal variation you have in asthma. So we will understand that as we are entering this rainy season, cold weather, you have more prevalence and more patients presenting with asthma. So they need to know about all this and how to avoid some of these outdoor allergens and what to do when they have an attack. So I think that is the most important, how to identify, avoid, and what to do.
Okay, great. So I think we have answered virtually all of the questions. We'll just make a few announcements which are very important for all of us now. Thank you, Dr. Eroja. Dr. Ofisoye, do you have any final comments? Or Dr. Eroja, Dr. Ofisoye? I'll make a few comments. Dr. Ofisoye, Dr. Eroja, do you have any final comments? I'll make a few comments, and that is related to how to manage it in COVID, but I'll talk about that after Dr. Eroja and Dr. Ofisoye. Please go ahead, Dr. Eroja.
Okay. Yes. I think we've done a decent job. For the most part, just remember that patients, they don't, the fact that they're on a particular regimen, maybe they started taking some difficult or dicey or might require a little more
Not hearing him as
careful
such.
planning, but always don't hesitate to step up the management. Like in the last question,
Dr. Eroja, we're not hearing you.
like the last question that was about seasonal asthma. Patients might. Hello, can you hear me now? Hello. Hello.
Hello, sir. We can hear you now.
Can you hear me now?
Yes.
Okay. I was saying that.
Yes, I'm hearing you better now.
Okay. That people should be ready to step up treatment. Like the last question that was asked about. Yes. Like the last question that was asked about seasonal asthma. It's important to be able to step up treatment when it's necessary. So people should remember that this step-wise manner of managing the asthma, they should always be ready to take it to the next step. And then once the precipitating factor is away, let's say it was harmattan, then also be ready to step back down once patient's asthma control is better. Okay?
I don't know if everybody was hearing him. I was not hearing him very well. Dr. Olalekan, were you hearing him?
No.
Or am I the one that is not? Okay, so I will just remind everybody that this time is the time of COVID. Essentially spreads the virus, aerosolizes the virus quite very seriously. So we need to be very careful about nebulization. Dr. Roger, once you are back on, you can just let me know. So you need to be very careful about nebulization in this era. As much as possible, if you have to nebulize any patient, make sure that you are wearing an appropriate respirator and you are in an appropriate room where possible. And the appropriate room should be a negative pressure room, where pressures are being sucked out. But however, as much as possible, try to reduce the use of nebulization and high flow oxygen, which may aerosolize the virus and make it more likely for healthcare workers to be infected. It's also important to note that when the virus aerosolizes, it stays aerosolized for quite a while. So it may be in the, and so even after the patient has gone, that room can still be infected, able to infect another person. So you should be very careful about that. Now, it's also very difficult, like somebody asked a question, to differentiate COVID from asthma. However, the thing that can help you, the patient has a previous history of asthma. The patient has been managing asthma before. If you put in all of these, the patient should hardly come with acute severe asthma that needs hospitalization. However, if they have come, you're a doctor, make sure you're wearing your N95 respirator mask. I don't have one in the office to show now. But make sure you're wearing an N95 respirator mask, or at the very least, you are wearing a surgical mask. Okay, everybody must assume that the patient has COVID, okay, as much as possible. There are quick, rapid COVID antibody tests that can be used. I think we use them in our facility to at least give us an idea. So they are okay. Still remember that you need to keep a good distance, at least 2 meters from patients, whether you are coming with asthma or not. Don't assume that patient has asthma, he cannot have COVID. There is nothing that stops an asthmatic patient from having COVID concurrently. So don't assume that, oh, we know this patient can always have asthma and now he's having COVID. No, they could have it concurrently. You need to take all the precautions as if the patient has COVID. Your guiding principle should be that you assume that all patients have COVID until proven otherwise. Okay. Having answered most of the questions, I'll just give some announcements. First of all, I want to apologize for those that have not received their CME. Sorry, we've been quite busy in the hospitals, so that has been delayed a little. Please bear with us. But after this presentation, all the people that have attended, you will receive in your email a link to just answer the questions and put your full name. Once you do that, you will get so you don't have to send, again, unlike before, you have to send a mail first before we now prepare the CME. So in this case, we have improved on that to help make it easier. Okay, so I want to just also give some announcements. So I've improved on that to make it easier. You can get your friends to join us every Friday. If they don't have the details, they can always send a mail to get the webinar details. Every Friday, Cardiocare and Limi Hospital does webinars. I will tell you what webinar we are doing next week shortly. A lot of people have asked for viral hepatitis. So we'll do viral hepatitis in 2 weeks' time, in 14 days. We'll be doing viral hepatitis. So make sure that you are there. Invite other people. We typically don't like situations where we have patients coming with hepatocellular carcinoma. I've seen so many of them. that come in, they have been to us that nothing is what they should just not eat protein, only for them to come down with PLCCs a couple of years later, you know, and PLCCs has a very high mortality. So those are some things we should check out, we should be careful about while doing this. So every Friday by 3 p.m. you can rewatch most of the lectures that we have had currently and previously on hypertensive emergencies, COVID and pregnancy, how you are put in difficulty in breathing, which asthma was also discussed there. What other things? We talked about chest pain, how to handle chest pain. We talked about insulin use in pregnancy. So if you go on YouTube, you'll be able to watch. It. Just search for the Limi Hospitals Network, and you will see quite a number of enlightening videos there. You can also invite your friends to rewatch this presentation on demand at any time, at least for the next 1 week. About an hour after the presentation, the rewatching will be available on Zoom and on Facebook, on Cardiocare's page, as well as the Dimitri Hospital's page. Okay, and I said that you will receive a mail once you answer the question, then we'll prepare your mail. Please bear with us. There's some delay in distributing the CMEs, but please bear with us. You will still get your CMEs as at when due. Next week, we're going to be doing respiratory distress in neonates. The Limi Children's Hospital essentially are warming up. The NICU there, they are all ready for this. Dr. Kefas, Dr. Peter, Dr. Habibat, they are. In fact, the stuff is doing press up already. I can assure you that, you know, you give birth to a baby preterm, at term or post-term, you know, and what to do. Baby comes out, is having severe difficulty in breathing. What to do? So next week, you should just tune in, people. We are trying to make sure that these teachings go around to many people as possible in Nigeria so that we improve healthcare. We believe that this is the way we can contribute to healthcare in Nigeria, and then let politicians do their own part. So respiratory distress in neonates on Friday next week to be an enlightening presentation. We will try and do some as much as allows to do some demonstration online, but limited to anchor that. And then if you need if you have any question when you ask, we'll try and find a way to demonstrate for you, particularly on one way or the other. So next week, respiratory distress in neonates. This presentation was brought by Cardiocare's cardiology, endocrinology, pulmonology, nephrology, critical care, intensive care. We do a lot of spirometry in Cardiocare as well, which was talked about today. And what essentially we do is that we do both the normal spirometry, that is just the where we give inhaled, you do the baseline spirometry, get all the figures. It's a very fantastic, unique. I mean, I wish we could show some of the pictures of the ones that we have done before. We do the baseline one, and then we give either we do salbutamol reversibility test to see that it's reversible to actually make a diagnosis of asthma. Okay, so we'll do that, and then we can also do the challenge test. So that we do in Cardiocare in our physiology lab. So it's also possible there. EEG, Holter ECGs, stress ECGs, ICU for critical cases, 24-hour emergencies. Is a 24-bed facility with ICU, ADU, emergency rooms, labs, you know, things, and there. We also have a cath lab, which is more or less the first functional cath lab, indigenous cath lab north of the Niger. So anybody that has a heart attack, we could easily do that. We're open 24 hours for that. We implant heart devices and also interrogate devices when the heart is very slow or is extremely uncoordinated. This weekend, we are doing about 5 cardiac resynchronization therapy. So we're putting CRT devices into the heart. I will show you some pictures. Essentially, we just pass wires like this through. This is what our cath lab looks like. And this is a picture that came with an acute heart attack. And you can see the blockage here of the proximal left anterior descending coronary artery. Okay, and then we went ahead to open that. You can see that there. So went ahead and we opened that. This is a procedure when we're inserting CRT. So we put in the leads and we screw them to the heart, and then they now tell the heart how to beat. Okay, like I've said before, these are the things that we do. Endocrinology, diabetes, neurology, we also take care of strokes. We have a stroke unit and our neurologists. I think one of the topics we're going to talk about going forward will also be stroke. Dialysis is also available at very, very low price, because we're just doing this just as a social responsibility. Our ICU, this is a picture of our high dependency unit in Cardiocare. Just thought you should see it so that you know what to do. Your ventilators are there, at least a few ventilators are there in the HDU, also in the ICU. Just like we talked about in hypertensive emergencies, the monitors also are measuring invasive blood pressure. So we're not measuring blood pressure through a cough. We're measuring blood pressure actually through the pressure inside the artery. So the IABP, intra-arterial blood pressure, essentially is measured there. General internal medicine is also done. Okay, so next week, the Limi Hospital essentially they do a lot of NICU. They have an 8-bed NICU. They are able to transport babies from the living rooms around Abuja. So if you have a neonate about to be born, but more importantly, we want to get you the information of what to do. The baby is already in respiratory distress and it's in your facility. What should you do before you even call for help? Before you call us to come pick the baby with our team, what should you do? So that teaching will happen next week. Respiratory distress in units. Okay. So once again, I want to thank everybody for joining us. Today. Thank you very much. We've had over 100 and something people registered. Not everybody was able to get in. Thank you for appreciating us. We really appreciate that. And for those that are here to get their CMEs, please bear with us, you will get it. For those that attended this CME, 24 hours after, you will get a link in your email. Just answer the questions. They're quite simple. If you listen throughout, you'll be able to answer the question. If you were not here throughout, then you just need to go back and click on the link and rewatch them. If you were here throughout and you think I don't answer the questions, then you need to rewatch it. Okay, you can also watch it on YouTube for the most part. Thank you very much. If there are no other questions, we will come to an end right now. I'll see you next week, Friday. Dr. Roja is a consultant chest physician. Thank you very much. Dr. Officer, Dr. Olalekan, thank you so much. God bless you.